and I am very excited to present today's Burncast is Burncast number 10. Can you believe we have done 10? We are the lucky 10 today. And in honor of that, I think that we should probably reintroduce ourselves because we don't do that very often. I'll go first. I'm Cindy. I'm the Injury Prevention, Education, and Outreach Coordinator for Trauma and Burn Surgery here at Children's. And I work in the same office with Liz Weibel. Liz, why don't you tell us a little bit about yourself and then you, Ann.
Sure. Thanks, Cindy. So I am the Trauma and Burn PI Coordinator, and I've been a Trauma and Burn NP with the service for 13 years now.
And I'm Ann Ciriello. I am also a trauma and burn nurse practitioner, and I've been with the Trauma and Burn team for over 4 years. I've been at Children's National for about 8 years now as a nurse practitioner.
And a fun fact about Anna and I is that we go way back.
We do.
I used to be a PICU bedside nurse, and Ann was a nurse practitioner in the PICU. So we've worked together for a long time.
Yeah.
And then if we go even further back, when I started at Children's in 2008, I was on transport and I had to do trauma days, and Liz Weibel was the teacher of that. So it's all in the family. So in honor of
small worlds.
I know it is. It's crazy. So
yeah,
it's a good
really
lesson
is.
for everybody. Don't burn your bridges.
Really? No, yeah.
Because then you end up working with everybody later on.
Mhm.
No pun intended.
It's right. Oh yeah, burn, haha. So today we are going to do a review of less commonly or maybe more commonly used dressings. So one of our first episodes, we talked about like all the different dressings and what to do with them. And it is pretty basic if you have a problem of like, what do you do with the dressing and all of that. And we've done extensive education on Aquaphor, Mepilex AG, Silvadene, and I'm forgetting one. Oh, bacitracin.
Zeroform.
Zeroform. That's the one I was thinking of.
Yeah.
And I guess this is also a good disclaimer time of like, we're not getting, we have no conflicts of interest, and we are only discussing these dressings because this is what we use in our program. And yeah, we're not getting paid for this. So, and this is just purely informational for our nurses specifically at Children's National. So Liz and so Liz, not only does she work for our trauma and burn surgery as our PI coordinator, but she also takes care of a lot of our kiddos in the outpatient setting at Friendship Heights. And Ann does inpatient and outpatient burn and trauma stuff within our hospital. So they see kids acutely and like throughout the whole process. And one of the dressings that I feel like I've seen a lot when we have our burn rounds. Oh, and let's talk about burn rounds. Liz, can you explain burn rounds?
Absolutely. So burn rounds is a multidisciplinary weekly burn PI meeting. So basically it's our burn attendings, especially the burn attending who is responsible for patients for the week is there. Our nurse practitioner team, our 5 East educators, as well as nursing is there too. And then we have social work and case management and PTOT. And so it's an awesome multidisciplinary, as I said, weekly meeting where we discuss patients that are either admitted, patients that have been seen in clinic that have either psychological needs. Oh, Dr. Tully is there as well. Patients that have, unique needs, or, maybe we bring a patient to rounds to talk about which dressing to use, or there's a social situation to be addressed. So it really is neat. And then we'll also talk about patients, we continue to follow patients well into their recovery. I mean, months, sometimes even years. So at times, if a family has a question, or if we see a kid for annual follow-up and there's a concern or something we just want to share with the team, that's the forum to do it as well.
And we'll also, I just want to piggyback on that if the patient is in the ICU, we'll include the ICU team as well. So they're welcome to join us for that if we have an ICU patient, which can be really helpful. And then we've had some patients go to rehab within like our institution, and we'll include those if we have a patient there.
Absolutely.
And so burn rounds is it's a great way to learn more about burns. And it was at burn rounds where I started seeing a few different dressings that we haven't provided a whole lot of education to the staff about. And I thought that today would be a perfect day to run through the previously less commonly used, currently now more commonly used dressings. And I feel like one of the big ones is Acticoat. So tell me about Acticoat. And is it like one dressing? Do you use it with two? What's it made out of? What does it look like? Does it have a weird smell? You know, because like Xeroform has its own smell,
Oh, yeah.
Silvadene has a smell, you know, they all have a thing.
Yeah, so Acticoat, I think we often will say Acticoat, and what we really mean is Acticoat Flex. So Acticoat Flex is a product that is a silver impregnated product. And the way that we use it here at Children's National is that we apply it with a silicone-based product. So we apply it with a Mepitel. We use Mepitel. There's a few different types of Mepitel, but Mepitel is a silver only. It has holes in it, so drainage can get through it. And the Mepitel that we use is slightly adhesive on both sides. So we take the Acticoat Flex, which either comes in a sheet or in a roll, and it looks brown because of the silver that's impregnated in it. We apply it to an adhesive side of the Mepitel, and then the other side, which is also slightly adhesive, is applied to the burn. So the the silicone is what touches the patient,
Okay.
and it allows for easier removal of the Acticoat. And we've found that it's just better tolerated, especially when patients are awake in clinic and doing bandage changes that aren't sedated in the operating room or something along those lines.
So it's burn skin,
Mm-hmm.
silicone,
Mm-hmm.
Acticoat,
Mm-hmm.
cling.
Sometimes
you
there's
get
a cling or a Curl-X or any sort of wrap. We will, because unlike Mepilex AG, which we use frequently, which has a foam and is a little bit more absorptive, this is not an absorptive product. It actually, as drainage goes through it, and you kind of need something on the other side to absorb that. So if it's your Curl-X that's doing that, we sometimes use an Exudry or a Mepilex pad or something like that to absorb the drainage on the other side of the bandage, or you just wrap it up in a bulky dressing with your cling or Curl-X, depending on the part of the body that you're using it on.
So what depth of burn do you use this Acticoat silicone sandwich with?
Oh, that's a good way to
It's a
call it.
sandwich. I'm hungry.
I like to use, personally, when in my practice, I like to use Acticoat Flex on anything that is a partial thickness burn that's threatening to be a deep partial thickness burn, that I see any sort of signs that I feel like this is a little bit deeper than just kind of a superficial partial injury that will easily heal with Mepilex AG, because it's a bit stronger penetrating. And I use it, we occasionally will use it on either deep partial or even some full thickness burns if we need to bridge them to daily dressing changes or wherever they may be going next in terms of the treatment of the full thickness injury.
So
Is that
is it a
about right,
daily
Liz, you
change?
think?
I'm sorry, what'd you say, Cindy?
You agree with that in terms of how we use it?
Absolutely, 100%. I think, we've always had in the back of our minds that if it's deeper than just a plain old superficial partial thickness pink moist blanching, that I think we've always had in the back of our minds that, we opt for this product instead. And I think, great explanation of using the Exudry on top. Again, the deeper the injury, it can be more exudative. So nice to not have all that dried junk on the dressing when it is stuck to the patient. You're trying to get it off in clinic. But also, Anne, it's easier to wrap a hand in Acticoat, don't you think?
Yeah, I do like it for hands because I think it, it has kind of a flexibility and then it is a little bit adhesive. So I think it kind of bends with little fingers relatively well.
So how often do you have to change that dressing? Like, do you send kids home in it? Is it only an inpatient thing? Like, do you have parents change it? I just don't know.
Usually Acticoat Acticoat Flex is changed by our providers, and it's something that it's a long acting bandage. So we put it on for 3 to 7 days.
Okay. So you can use it in the hospital and you can use it outpatient, because if it lasts,
I've put it on I've put it on in the emergency department, clinic, the operating room, the PICU, the floor. I've used it in every setting that I see burn patients.
So can the Acticoat Flex touch the skin, or do you put the Mepitel like in between it just to help it not get stuck to it? Like, why do you have to do that? Or is that like a preference thing or?
That's a preference. That's how we like to use it. I think if you talk to the manufacturers, the Acticoat Flex can go directly on the skin. We
Okay.
find that it is better tolerated with the silicone product in between.
And when you say better tolerated, like, what does that mean? Like, is it
It's
painful?
easier to remove.
Okay.
Yeah, I think it's easier to remove. And I think it is less, yeah, I think it's less painful when you're taking it off. And I think that it works better with the silicone in between, which is kind of more so from Anne's Journal of Anecdotal Medicine, and not necessarily that there are any like RCTs or randomized controlled trials about this. But I find that I think I don't know exactly why, but I think that the burn heals better with the silicone in between, or maybe it just doesn't peel off as much of a scab or kind of peel off the new fragile skin. I don't, this is kind of a little bit more of a gestalt thing, but that's how we do tend to use it.
Mhm. I think if you didn't have that bilayer, again, it's so crucial to kind of, again, leave that healing skin behind. You're going to have just a really dried mess on your hands. It's almost like an overlying scab on the flex, and then you pull it off. There's going to be a lot of secondary trauma and bleeding. So yeah, I think
Is this kind of like a replacement for like a drip method where you know how, because when we went to ABA, I participated in a couple different lectures where I was listening, not just watching, I was using my listening ears, and they were talking about a lot of like in adults, they do like a drip method where it's like this constant infusion of like something to make sure that the burn didn't dry out in hospital. And I was wondering, like, is the Mepitel kind of like that, but just like a long-term thing? Because I can't imagine doing a drip method with a kid, especially outside of the hospital. Or am I completely like off base of like hearing about that and then putting those thoughts together?
I think that the Mepitel provides a layer that is less likely to adhere to the burn. And even though I'm saying that it's like a little adhesive on it, I know that doesn't make any sense whatsoever. But I think that the Acticoat Flex is a very dry product, and it doesn't have it's a fine, almost like a very, 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 very fine mesh in a way. It's kind of how you can think of it. I don't have one in my hands, which probably would have been a good idea for the video aspect of this, but it's meant to have kind of fluid drain through it. I think the silicone product, and if that gets really wet, it can sometimes, the Flex actually like kind of stick and dry almost into a scab like fashion. And so if you pull that off, you can kind of pull off some of the skin underneath of it, is my kind of assessment of how this goes. And that the silicone layer really helps prevent that and comes off a little bit easier, especially as all of this can dry, because if we use it in partial thickness injuries, as they heal, they dry, but then you're kind of taking this dried bandage off of dry skin, and sometimes that can be challenging to get it to remove without pulling off either the recently epithelialized skin or scabs or something along those lines.
Okay.
I like the way that the Mepilex is a little sticky.
Yeah.
And wounds need a little bit of moisture to heal too. They can't just be like totally dry. Think about like a skin knee. Needs a little bit of an ointment and then a bandage for covering. So.
Well, and I think that that's like one of like the main tenets of like any type of like burn or wound healing is don't let it dry. Like don't let everything get dry, especially like in the beginning stages.
Many people say that they think that they need to let it air out, but we don't feel that way. We like to have our bandages in place so we can use our treatments on the burn injury instead of letting them air out and dry, and then you kind of get a layer of scab that it's harder to penetrate through with our bandages.
New skin can't grow through a scab, and that's the whole purpose, right? We just want the new skin to grow. So does Acticoat, is it perforated or is it like a solid sheet? Are there like holes through it, or
not very visible holes? It's almost like a piece of fabric.
Okay.
where you would say, or like a
Cheesecloth,
cheesecloth,
yeah.
but it's like in
Okay.
between like a cotton and a cheesecloth. Like it's, you wouldn't see holes necessarily, but if you held it up to the light, you may feel like you could, like it's a very finely woven, you know, thinking about like sheets thread count or something. I'm sure you could do the thread count of it, but
Okay.
it's you know, I'm trying to get to it, but and it does, it like flexes like a piece of
Mhm.
fabric. Like it
Okay.
it comes in a roll or a sheet, and if you drop it down, it kind of falls into like a little ball or whatever, because it's more like a piece of fabric.
Okay.
Acticoat makes another product that's just Acticoat, and that one looks more like a piece of tinfoil.
Yeah.
Which is the best way that I can describe it. And it is not, and when you hold it up, like if I were to hold it up, this is, sorry, what I have. If I were to hold it up, man, the background's not helping. If
That's
I were to
okay.
hold up a piece of Acticoat, it would be like a sheet. But if I hold up a piece of Acticoat Flex, it's kind of more like this, you know,
Oh, so like fabric versus
Yeah.
paper.
Yeah.
fabric versus
Fabric versus
paper.
foil.
Foil.
Fabric versus
Yeah.
foil. Okay. Okay. Does Acticoat Flex have a smell?
No.
Mm-mm.
When the drainage comes out, does so for all of the burn dressings that we've talked about in the past,
Mhm.
whenever there's drainage, there's always a smell.
Yes.
Is there a different smell
So-
with Acticoat Flex, or is there like what's a good smell versus a bad smell, good color versus bad color? Like what do people like? Because we just went into like a very long like explanation of like what Acticoat Flex is and when we use it, but now to get to like the nitty gritty of like if you see a patient with this on it, like what's normal and what's not normal?
So it needs to stay on, as Ann said, for like 3, 5, 7 days. So the kid's not taking a bath. This dressing is staying in place. And so we tell parents that the kids are probably going to smell like a sweaty sock, right? Because kids are still going to run around, hopefully, and sweat, and again, not get baths. So that's not necessarily a bad smell. So I kind of, they smell like sweat, and that's okay. It's okay to smell like sweat.
Okay.
And then some normal drainage. If you imagine again, silver, when silver tarnishes, it's kind of produces like a grayish brown color. So sometimes you'll see that what we call strike through. So it's fluid that's tinted by the silver on the outside of the dressing is kind of takes on like a brownish.
It's not
grayish
dirty.
tint.
It's just
not
the
dirty.
silver.
It's just
Okay.
silver.
I think
it's
that's very
fluid
helpful.
that's gone through the silver, and so it's kind of again this tarnished appearance. So that's what's normal. Abnormal would be like a grossly purulent appearing wound, so yellow, greenish,
Malodorous, like
smells
really
bad,
malodorous.
like,
Yeah.
ugh.
So there's
Um,
like normal stinky sweat, and
right.
then there's like something's not right here.
Right. And
Right.
also the
It's easy to know the
degree,
difference.
the degree of exudate, like okay to, again, as we say, have some strike through, so some drainage on the dressing. You don't want to be able to wring it out though, right? That's bad. So those are the things to look out for. Malodor, drainage that's not kind of a grayish brown color, and then excessive drainage, meaning that it's a deeper injury or potentially infected.
And I would say that generally when we're using Acticoat, it's such a thin layer. So between, even with the Acticoat and Mepitel, and we're bulking things up on top of it, you definitely can see strike through, but it's going to be hard for you to see like the burn itself unless you're changing the bandage or it's kind of slipping around or something along those lines. So you may most know that there's an infection or concern with a fever or the smell you may see most. But generally when I have patients and I'm applying Acticoat in clinic, one of my kind of pieces of education that my pearls that I give to parents is you will see drainage come through and it will be brown, and that's from my bandage. That's not from your child's like burn. That's kind of the strike through coming through the bandage. So don't be alarmed by that, which I think is very important.
Yeah, and very helpful, because as a parent who didn't have whose child had never had a burn injury, and now they have a dressing on, and then you see brown stuff coming through the dressing, I'm sure that would be extremely distressing
Yes.
for a family member or for a bedside nurse who hadn't seen
Mhm.
Acticoat before. I'll tell you what, if I
Yep.
had brown on my dressing, my instant thought would be that it was stool from somewhere. I'd be like, we need to change this. But that is not always the case, especially if it's like,
Mm-hmm.
far away from the source. So there you go. Okay. Anything about Acticoat Flex that we haven't talked about that you think would be really important for our nurses to know, or if a surgical resident's watching this, or like a community ER physician, anything that you think is important?
Logistically, we stock it on the 5th floor, and it's not stocked in our emergency department. I think it's in our operating room as well, but it's not something that you will easily find unless you know where to look for it almost. So I think that's important to know. If you are having issues with it, I'm sure you could find it, but you can always call the burn team and we can assist with that and kind of figure out. Usually the dressing changes with Acticoat are done by our team.
Is Acticoat Flex used for anything else other than burns?
I mean, I think that's how we
imagine
use it
so.
for, but you could use it, in
Yeah.
theory, you could probably use it for any type of wound coverage.
Yeah.
Yeah, I was just wondering. I was like, I wonder if they use it for anything else in the hospital. I don't know.
At our
That's awesome.
hospital, I don't know.
Yeah.
That would be a question for the wound team. Yeah.
I'll ask them, maybe they use it for pressure ulcers. Okay, well, anyway, another thing that I've heard, so one of the things that I've heard in burn rounds said a lot is triple cream. Now, when you say triple cream in the PICU,
Mhm.
that means that we got a really bad diaper rash going on. I'm
Do you know what's in
assuming,
triple cream in the PICU?
I was wondering is it the same thing that you
I-
put on burns?
I think the triple cream in the PICU is Desitin, which is a
Mhm.
zinc-based product, and nystatin
Mhm.
Yep.
and cholestyramine.
Yep.
And
Yes.
cholestyramine binds with the bile and helps like remove, because usually it's in a setting where a patient is having a lot of loose liquid stools and you've got a really bad diaper rash. So the nystatin is to treat anything fungal. Cholestyramine is to kind of like draw the loose liquid stools away from the buttocks, and the zinc is, or Desitin or whatever product is, to kind of coat the skin
Yeah.
and protect the skin. Yeah, that's not our triple cream.
Yeah, I didn't think it was, but it's
Yeah.
funny because everybody, like, if you're in the PICU and you hear triple cream, you don't think burns,
Yeah.
you think butts,
Mhm.
which is
Mhm.
probably not the way to say it, but you think like diaper rash.
Yeah.
So
Yeah.
tell me about triple cream in burns. What is it? What would you use it for? And yeah.
So in burns, it is a mixture of hydrocortisone and mupirocin, which is Bactroban, and nystatin, either cream or powder. Although I think the preference is to use the powder, right, Anne?
I like the powder because it kind of pastes it up a little bit.
So this, you can use it when burns take a while to heal. We usually use 3 weeks as our threshold. When it takes more
So
than
these are like outpatient kids.
Yeah, yeah,
okay,
you're
so
probably
they're
not going to see
doing this
much of
in-person.
it unless you have an admitted burn patient who's been in the hospital for, for many weeks and burns have mostly healed, but maybe you still see some open areas. So we usually are using it for patients who have prolonged wound healing, plus minus infection. But what you see at that point is you may have some satellite areas in the burn that are still open, with bright pink tissue. We call that hypergranulation tissue. It's just the body's response when there's a deeper injury to try to heal itself. And by doing that, it produces this friable, so like really fragile pink tissue that's moist. And we just need to, be done with it. We want wound coverage. We want these things to be scabbed over. So it's an effective way to dry out that hypergranulation tissue.
So it's like the antithesis of early burn wound care. It's like, this needs to heal. This is the time where we want it to get dry.
Right.
Yeah, so the
that dries it out.
hypergranulating tissue is like kind of beefy and sometimes like looks larger and inflamed, and it's the steroid, it's the hydrocortisone that kind of helps dry it out.
Does
And
it
we
help
use
with
the
itching too? Does a triple cream help if the kid's itchy with all the hypergranulation tissue?
usually the itching is from either dried skin or a hypertrophic scar. So that's not necessarily the same type of treatment. Usually, and a lot of times when our patients are itching, I'm going on a tangent here, but I'm semi-answering your question. A lot of times when our patients are itching, it's because they've been in a bandage like Acticoat or Mepilex for 3 to 7 days, and they have some epithelialized, dried, healed skin, which means that it's healed and the bandage has been in place for a while, and it's almost like you have like a dried spot you can't get to, and it hasn't been moisturized in a while. So that's usually where we get our like short-term itching from. And you can also get long-term itching from thick, kind of hypertrophic or keloid type scars.
So the cortisone is more to help with like the
Mhm.
ballooning of the tissue, not for any itching. Because I think
Right.
that
Right.
a lot of time when you hear cortisone,
Mhm.
you think
Yeah, bug bites and
think
yeah,
itching.
poison
Yeah.
ivy, yeah.
You
Yeah.
think eczema or something like that.
Yeah, but we're using it to really just kind of settle it down, and it wouldn't be over the whole burn. We would just use it over
Mhm.
those residual open areas. And so,
Do
as
you cover that or do you just put the paste on? Do you,
I would advise that it's covered just so it doesn't ruin any clothing, and so it actually
Yeah.
stays on. So under a bandage or
Mhm.
nonstick pad or something like that. But usually these
Mhm.
are like much smaller areas. The majority of the burn has healed, but there are just still some residual open areas. So
do you
coverage is
make it or
good.
do you order it? Do you order triple cream or like, so again, like in the PICU, if you are
Mhm.
doing like the diaper rash stuff, you kind of like get all the ingredients and then you're kind of like and mixing it up. But for the triple cream, do you just order it or do you make it?
We order the 3 components,
Okay.
and then we advise to mix it immediately before applying to the burn injury. So I will actually take whatever I'm applying it on in terms of the exterior bandage. So either a nonstick gauze or a regular gauze, whatever I'm choosing to use because of the location of the body and the size of the area that's open. And I will just like kind of squirt roughly art, not science, equal parts of the 2 ointments and like sprinkle of powder and then mix it together on my like Telfa or bandage and then put that on the patient. That's how I do it.
Okay.
Mhm.
Liz, is that how you do it too?
I don't use as much of it. So I've just you have to prescribe the 3 different components. So I guess that's an
Mhm.
important teaching point for, the family if they have a prescription for
Mhm.
it. It's like it's not just one prescription, it's 3 different. So
Mhm.
that sounds like a good strategy.
So when you're talking about like hypergranulation tissue, what is the other thing that you put on hypergranulation tissue that's not triple cream?
I can think of 2 other treatments that we use
Yeah.
for it. One is called Gentian Violet.
Yeah.
And it's it is used, it's this bottle of basically purple liquid, which will absolutely stain if you spill it on something, say like your watch band or the operating room floor. I don't know. I mean, those are just a few examples that come off the top of my head if I were to like make them up, but it certainly can stain, and you apply that to the areas of hypergranulating tissue as well.
How do you put it on that? Does it stain the skin?
Mm-hmm. I either
Forever?
apply it with a Q-tip, a gauze, or a syringe, depending on how big the area is and where
How
I'm trying to
much?
get it.
Just paint it
Until it turns purple.
until it turns purple.
Okay, and it's a liquid?
Mm-hmm.
So the bottle, would you say like 2 inches tall? It's a little bottle, right?
The bottle's probably 30 mLs.
Okay, and so
Right.
Yeah,
you
about that
just
big.
drip some on and paint it onto the hypergranulated tissue.
Mhm.
So if it gets onto tissue that isn't hypergranulated, what happens?
Just stains it purple and it comes off a few days later.
Okay, so it's not stained forever.
Right.
Not on the skin.
Okay.
Maybe on your watch band or the operating room floor, potentially, but
Skin, it goes
not on your
away.
skin. Yeah.
And does it hurt? Like, does it burn or anything?
I have not had patients tell me that it burns. I have
No.
had some patients be a little bit sensitive because this
don't
is
want
like
you
an open
touching
area
the
they don't
area.
want you touching,
Yeah.
right?
Yeah.
But not that this specific treatment burns.
Is there any place you wouldn't use Gentian Violet?
Face.
Okay.
Yeah, I probably wouldn't use it on the face. I wouldn't use it unless we have hypergranulating tissue. Like I wouldn't just put it on a 3-day-old burn.
Okay, so hypergranulation tissue. So that's just another way to combat it, is this
Mhm.
the Gentian Violet. Do you ever use it? Like, what makes you think Gentian Violet instead of triple cream, or triple cream instead of
Mhm.
Gentian Violet?
I think triple cream. So we often try and limit our triple cream use to 5 days because of the steroid component. Sometimes we'll
Mhm.
do like another 5-day course, but I think triple cream is when you're seeing some like really like hypergranulating tissue and you're like, we got to knock this down, and you're still doing daily treatments. One place where I really like Gentian Violet personally is on a patient who has a large TBSA burn and is pretty far out, and they just have some scattered open areas. And what I'm trying to do with the Gentian Violet is like dry up some of the areas so that I can leave their extremity or whatever area open. Because you may find that a patient has 10% TBSA burns to an extremity, and most of it's epithelialized or healed or scarred or whatever it is. And then you have these like small spots that are spread out. And I really have to wrap their whole arm for like 4 small spots. And I find that Gentian Violet is a really good spot where you can kind of get something to dry up and almost look like a scab. And then you don't have to have a bandage on it. It's a little bit less sensitive. So that's where I really like it.
Mhm.
It kind of gets patients out of daily dressings sometimes when they just have some small scattered areas.
How do you send it home with families?
You can get it, you can get it over the counter. You can order it on Amazon. But you can
Do
buy
you
it.
have families like apply it? So say you put it on a kid in 3 places in clinic and
Yes.
then send them home. Like, do you have the parents like do
I think
it
it's
or?
I think it depends on the degree. If you have like a teeny tiny area, I would paint it on and I'd say, hey, just protect it with a little bit of Xeroform. And this should do the trick. If it opens up again, get some over the counter and dab it again, dab it yourself on yourself at home and do it every other day. Again, it just depends on how big it is. Sometimes just one application in clinic with some Xeroform at home can do the trick. But if it's a wound that we're treating and we're like 6-8 weeks out, then oftentimes the family will have to get some over the counter and just, apply it every other day with, Xeroform for protection or, as needed.
If a kid puts it in their mouth, do they need to call poison control? Because if you're sending it at
Actually,
home or
it is used for thrush.
oh, interesting.
Yeah. So no, I don't think so. But
Mhm.
I'd look at the bottle. But yeah.
Because I know we talk a lot about like one of our things that we clean burns with is Vosh.
Mhm.
And even though it smells like chlorine, if it gets in a kid's eyes or nose or mouth, like it's like it's
Right.
fine. I mean, nobody's going to drink a bottle of it, obviously, but I
Mhm.
always wonder like what happens if a kid gets Gentian Violet in their mouth. So I didn't know that they used it for thrush.
Purple
Mhm.
10.
Huh,
Yeah. I
interesting.
mean, I think nystatin is a lot better used for thrush, but I think
Right.
it's kind of more like in the past, it was used for thrush.
Obviously, nobody should be drinking it.
Mhm.
Right. But yeah, I was just wondering if kids have it at
I
home.
mean, if
this
somebody
is
drinks a
something-
bottle of Gentian Violet, you should probably call poison control.
Yeah,
Right. So
that's fair.
1-888-222-2222, I think is what the number is, or something like that.
1-800-222-1222. It's a Mr.
Yeah,
Doc.
that's it. Yep.
Yep. Yeah, I was just wondering like if a kid got it in their mouth, because if it's not supposed to be on the face, I worry about it like getting in the mouth and then, stuff like that. So you said that there was two things. One of them was Gentian Violet. What's the other thing that you use for hypergranulation tissue?
Well, sometimes we'll use silver nitrate,
Mhm.
which we usually do in the operating room, just because it can be a little bit painful, especially if you're getting on the surrounded skin. But that's another treatment for hypergranulating tissue.
So tell us what silver nitrate does, because it's intense.
It basically
Sounds like you have
burns.
experience with it.
Yeah.
I
Yeah.
do.
It burns the hypergran tissue to kind of get it to scab over.
How
So
do
it
you
creates
explain
this-
that? Oh,
It's
well, I guess
the
Andy just
chemical
said that you do it
cautery.
in the
Yeah.
OR.
Yeah,
So
chemical
yeah.
cautery. There you go.
Yeah. And this is not a burn patient, but it's used a lot around G-tube sites when patients have truly hypergranulating tissue, and that tissue doesn't have nerve endings in it. So if you protect the tissue around it really well, you can, and on the umbilicus of newborns, they'll sometimes use it. So if you protect the surrounding tissue, it's not painful to the hypergranulating tissue. But in our burn setting, it sometimes can be hard to say like, this is definitely hypergranulating and has no sensation versus like it's sensitive. So
Oh, I totally forgot about silver nitrate. Yeah, it was ordered for one of my patients in the PICU, and it came to the bedside, and I'm looking at this and I'm reading the order, and I was like, you want me to do what with what? And it's
Yeah.
like warning. There's like
Yeah.
82 different warnings on the because it comes in like a tube,
Uh-huh.
like
Yep, it's
like
a
it's like a
stick.
big thing
Yeah.
of matchsticks.
Yeah.
Yeah, it's like, I don't know, like 10 inches long, and it comes in a
Yeah.
little tube, and then you open
Mhm.
it up and you take out the stick, and then I was like, do you like, you just put it on there? And I was like, oh,
Yeah.
that's exactly what you do.
Mhm.
But yeah, it's interesting. I'm glad that we most of the time do that in the OR, because I feel like that would be a hard thing to explain, like in a clinic appointment,
Mhm.
or even at the bedside. It's definitely an impressive thing to like try to explain chemical cautery to anyone. Well, wow, we've been going for about a half an hour, and I still
Really?
yeah. And I was like, oh, I don't know, should we talk about one more thing, or should we
Sure.
wrap up? How do we
Up
feel?
to you. You're the boss, whatever you think.
Let's talk about collagenase,
Okay.
because I really know nothing about collagenase.
Mm-hmm.
So tell me about it.
Collagenase
I
is
just
an
hear it a lot.
enzymatic. It's an enzymatic debreeder. It's the generic is collagenase, and the brand is Santyl. So you may have it Santyl. It may be called either one of those. And so basically, it works on deep partial or full thickness burn injuries where you have either eschar or pseudo-eschar, and you're trying to get something like Miss Pac-Man to eat at the overlaying eschar or pseudo-eschar. That's how I
It's
think
like
of it. It's like an
Silvadene.
enzyme. Like
It's
it
like
works similar to
Silvadene.
Silvadene. Mhm.
Yeah.
Yep.
Yeah.
Is it the same
It's
color?
No, it's clear.
Okay.
It's like a clear ointment. It looks a little bit like a thick Vaseline, almost like a Vaseline coming out of a tube.
And do you put it on the same way you put on Silvadene?
Collagenase does not have any antimicrobial properties. Silvadene does. So Silvadene can go on a burn by itself. Collagenase we often use with something that has some sort of antimicrobial coverage. The options for that are usually Mepilex AG. So what you do is you apply the collagenase to the burn, you put a Mepilex AG pad over it, and then you remove the Mepilex AG pad, and you can actually save the Mepilex AG pad and use it for a few days. You wash the patient and their burn, and then you apply more collagenase after you dry it off and get them out of like cleaning the burn injury. So you apply it every day, but you can reapply the same Mepilex AG pad for a few days. Occasionally, if I have a burn where most of the burn needs something like a Xeroform, I'll put it on Xeroform because that has bismuth in it, and then I'll put the collagenase on like the deeper area that just needs to be cleaned up a little bit more.
And why would you choose collagenase over Silvadene?
That's a really good question.
I'm thinking it has more dressings, because
Yeah,
you're
and
using that and Mepilex. With Silvadene, you're just using Silvadene.
Yep. When something truly looks like eschar and I don't see anything pink and I don't see something that looks like it's close to bleeding or bleeding, I find that it's a really appropriate use for Silvadene. So like collagenase is a little bit more gentle, and I use it in instances where there's a little bit of something that needs to get cleaned up, but it's also, there's some nearby very friable tissue that I think Silvadine's too powerful for.
Okay. So just like the Acticoat Flex is a little bit for burns that might look like they're getting worse, the collagenase is for like bad burns that might not be as bad. So it's like kind of like both of those are like the in-betweeny stage.
Yeah, you might have gone through like a course of Silvadene and we've cleaned up a lot, but kind of it's time to transition to collagenase and let it gently clean up the rest of it without like Silvadene on a burn that doesn't need Silvadene can kind of make it like bleeding or hypergranulating, and collagenase is a little bit more gentle when it comes to that. And collagenase is also extremely expensive and not readily available at local pharmacies. So we can get it, but it's more challenging to get. So that also can kind of impact your decision. Also, silver or collagenase we'll use a lot of times on faces and like ears and scalps, where in areas that we're less likely to use Silvadene.
Okay, that's a good point, because we don't typically use Silvadene on the face and or the ears. So for the ears, and the scalp and the face, you can use collagenase.
Yes.
Okay, that's good to know. All right, Liz, what do you have to say about collagenase?
Historically, we would actually use it more for traumatic wounds, road rash, like bad road rash, or like, deep puncture wounds, things like that. But yeah, we're definitely seeing it used more and more in partial thickness injury these days. And I think, as Anne suggested, the overuse of Silvadene can have detrimental effects too, right? So if you use too much of it, or if you use it for too prolonged a period of time, then you have the whole hypergranulation tissue problem. So, so that's why, we keep bringing patients back, or we'll check in with photos or telemedicine, just again, to make sure that we're not over treating, that we're appropriately kind of downgrading treatment throughout the course.
Okay. So today we have talked about, we started talking about Acticoat Flex and how you put the Mepitel in between. So you make the little sandwich. And those are for partial thickness burns that are deeper. So not the superficial partial thickness, it's the deep partial thickness where you're starting to get a little bit more worried. Then we talked about hypergranulation tissue. Now, this is something that happens, like you said, like 3 to 4 weeks after the burn. And then those 3 options were silver nitrate, which is the chemical cautery, gentian violet, which is that fun purple stuff that stains OR floors and watch bands, and then triple cream, which is not the stuff that they use in the PICU for diaper rash. This is the stuff that had cortisone,
Mupirocin,
nystatin, and mupirocin. And then finally we talked about the collagenase, which is like Silvadene but not as strong and can be used on the face.
I love collagenase. I wish it were more readily available and cheaper. Just putting that out there.
Yeah, I don't know
if I could, I would use it a lot more than I do. Actually, I think I do like it, and it's challenging to get and sometimes really expensive. And so it's like, you're not going to use it on a teeny little area, but sometimes we do.
And I really liked how you explained it's like Miss Pac-Man eating away all of the stuff.
Every time I put it on and I'm like, it's an enzymatic debrider, it's like eating at the little piece. Like, I'm like, I kind of just think it reminds me of Miss Pac-Man eating away at that. Yeah.
All right. Well, okay. So it's about that time. My favorite part of Burncast, of like, if you had one thing that you want people to walk away with, and I'll go first, that I think that that we have to remember that not one patient is the exact same as another patient. And the burn dressings are definitely an art, and it comes with a lot of experience and knowing what works and knowing what doesn't. And sometimes you have to change the course of treatment based off of how the patient's doing with that. And, there's so many things that factor in. So like, us as nurses need to remember that just because we did it one way with one kid doesn't mean we're going to do it the same way with the next kid, because each kid is different. Each burn is different. Like, the temperature of how they got burned is different. The mechanism is different. So I think that we should all have like a really good understanding that it's an understanding that we might not have the best understanding of what's being done, but always to ask a question, and that our nurse practitioners are awesome, and we'll be able to explain that to us. All right, Liz, that was me. I was long.
Okay. Oh, I liked
that. Was a good one though. I liked it.
I know.
That's why I went first.
I liked how you described it as an
that
art.
was.
I totally was going to kind of go in that way. I would make sure for admitted patients that you use the videos, have the families watch the videos. There can be so many nuances to care, right? Some of these dressings stay on 3 to 7 days, or up to 3 to 7 days. Some dressings are daily, some are twice a day, like, facial care. So have families watch the after the burn videos. And when they're being discharged as well, make sure they have all the videos they need for everything they need before they come and transition to the outpatient world, like the burn clinic video, etc. So watch the videos.
And Anne, close us out.
Okay, wait, it's my biggest tip from today. I mean, obviously I'm just killing time because I've done this 10 times now, so I know what you're asking. Let me think. I really liked Cindy's. I think my biggest take home from today is that there's a lot of weird things that we do, and sometimes Liz and I will look at the same burn and do things differently, and that I'm always happy to discuss what bandages are, and I don't think it's ever like a stupid question to ask, to say, what is this for? Why are you putting it on this part of the burn versus not that? And just reach out to our team, because we use a lot of different treatments, and some of them you've heard of, and some of them are kind of funky, like the ones we've talked about today. But so we've come to like some of them, or are using more of them more frequently. So I say just please be open to us and ask us questions, because I'm always happy to talk about burns.
All right. Well,
And
thank
happy
you.
10th pod.
I
burn
know.
cast.
Happy
I know.
10th burn
Sorry, I called it a
cast.
podcast.
Woo!
Happy 10th burn cast.
I know we should have sang happy birthday to the cast.